Hello, everyone. My name is Amisha. I use she, her, hers pronouns, and it is my privilege to serve as the Executive Director for UConn Global Health Spaces on campus. It is my pleasure to welcome all of you to the second day of our fourth annual Global Health Symposium, Decolonizing Global Health. For those of you that are joining us for the first time today, Global Health Spaces on campus was established in 2018 by a group of passionate undergraduates from many departments and schools at UConn, all united by a common goal to establish UConn as a global health center across the country. Since then, we have organized 3 annual global health conferences, engaged hundreds of students and faculty in the global health conversation, networked with changemakers across the globe, and gained national and international recognition for both our organization and symposium. In our efforts to engage students and professionals from all disciplines in global health changemaking, we established an annual Global Health Hackathon, where for 2 years in a row, students from all academic and pre-professional interests have come together to develop solutions to the world's most pressing global health issues. Of course, all of this would not be possible without the help of our generous sponsors and partners. I would like to thank Global Affairs, the Human Rights Institute, Dodd Impact, the Research Program in Global Health and Human Rights, the College of Liberal Arts and Sciences, the UConn Sociology Department, the UConn Anthropology Department, and the UConn Individualized and Interdisciplinary Studies Program. I would also like to thank the countless student organizations and departments, both here at UConn and across the country, that have shared this event with their students. And of course, a huge thank you to my friends in UConn Global Health Spaces on campus who have worked tirelessly over the last few months to make this weekend's programming a reality. As we discuss decolonization this weekend, we must remember that this is not a conversation about just other countries and areas around the world. Rather, the impacts and long-lasting effects of colonialism can be found here in the United States, with our history of colonizing Native American and Indigenous lands. Thus, before we start our event today, we would like to begin by acknowledging the Mohegan, Mashantucket Pequot, Eastern Pequot, Schaghticoke, Golden Hill Paugussett, Lenape, and Nipmuc peoples whose traditional lands we currently stand on. We recognize and respect Indigenous peoples as traditional stewards of this land and the enduring relationship that exists between Indigenous peoples and the land. It is also worth noting that the town of Mansfield, and by extension, the University of Connecticut's existence and legacy, would not be possible without the labor of enslaved Black people. We acknowledge, respect, and honor those whose forced labor allows us to work, live, and learn in this space. Over the course of today, we will continue to explore the concept of decolonization and its influence on healthcare, health outcomes, and much, much more. Last evening, we heard a keynote from Dr. Nicole Starr, who presented what decolonization looks like in the field of global surgery. Today, we will begin with a panel themed around international perspectives in global health, where we will feature global health leaders working on the ground from all corners of the world. Later, we will also hear a keynote from Dr. Jolade Kalinowski, who will present on her research on the relationship between stress and cardiovascular disease disparities in Black women and on the social determinants of health here in the United States. Tomorrow, we will be hosting a think tank networking and reflection session where glohsoc members will present some information regarding decolonization of global health, and attendees will have the opportunity to talk to one another and chart their own path into global health changemaking. Over the course of this weekend, we hope to immerse ourselves and all of you in the vast field of global health. We will discuss not only health inequities in the United States and across the globe, but also help you understand the common underlying socioeconomic, geopolitical, and cultural determinants that contribute to them. You will have the opportunity to look at the nuances of healthcare, acknowledge the hurdles that exist, and think critically of how we can craft creative, culturally competent solutions to those problems. We encourage you to keep an open mind and an eager heart, and learn from not just our presenters, from also one another. We encourage you to network, especially during tomorrow's Sunday session, and start thinking about how you can take what you learned this weekend and apply it to your everyday life and possible future career path. We hope that you walk away from this weekend knowing that you have the ability to have a huge impact on the field of global health, and that every one of you has a critical role in breaking down barriers and colonial legacies and building a healthier, more connected world. By choosing to be here today, you have already taken your first step towards working for a more equitable world, one where every individual has access to quality and affordable healthcare, regardless of their background, beliefs, or circumstances. UConn Global Health Spaces on Campus proudly presents our 4th annual Global Health Symposium, Decolonizing Global Health. On that note, I would like to hand the floor over to Bhavna Gunda, our UConn Global Health Spaces on Campus panel coordinator, who will be moderating our panel this morning.
Hi, everyone. My name is Bhavna, and I use she, her, hers pronouns, and I'm this year's panel coordinator focusing on decolonizing global health. So the history of global health traces back to the field of tropical medicine, where former Western powers studied infectious diseases that were prevalent in their tropical colonies. The goal in studying these diseases was to protect their Western colonizers from becoming infected and bringing these diseases back to their home countries. The term tropical medicine is still used in former colonies, but in the rest of the world, tropical medicine transitioned to international health and then to what we now know as global health. Now, more than just protecting colonies from tropical diseases, the field of global health works to improve health equity worldwide. However, in acknowledging these advances, we cannot ignore the lasting effects of the old colonial powers in the field. The current ecosystem currently includes structural violence from the history of slavery, racism, and capitalism that manifests itself in today's health inequities. These colonial patterns on marginalized communities also extends to areas like our common knowledge of health and our response to pandemics. We can ask questions like, why does America's history of redlining exacerbate environmental racism in our country? Why do we choose to prioritize the urgency of some diseases like Ebola over ones that have plagued countries for decades? We can even ask questions like, where do we hold health conferences, who gets to attend, and who controls the funding of them? All of these discussions have then spurred a movement to decolonize global health, but what does that mean and how do we do it? Decolonizing global health is minimizing the influence of colonialism in order to create more equitable health systems. One way to do this is to take horizontal approaches to tackling global health issues rather than vertical approaches. So instead of planning mission trips that last a couple weeks to provide temporary support to a community, we should be working with them to change and fix structural problems within their healthcare systems. We should look to the communities to provide guidance and let them lead the change. This works to create a system of permanent institutions that allow communities to be self-sufficient and self-reliant. Decolonizing global health can also mean dismantling what we traditionally think of when we use the term global health. Western and internationally dominated organizations govern and fund public and global health agendas, exerting their power over nations. Advocates also criticize that global health has become a term that reflects the viewpoint of the developed world on the developing, where developed countries like to help developing countries and these countries become charity. There's no single way to make change, but we can start by addressing the colonial influences on today's health structures. Throughout this panel, we aim to explore what decolonizing global health means and what it looks like to different people in the field and what steps we can take towards it. For this panel, we wanted to hear from professionals living and working on the ground across the world that understand the daily lives and the cultural and social norms of the communities that they are in. It would be remiss of us to feature speakers who travel infrequently from Western countries with the intention of helping or fixing other communities. So on that note, I would like to introduce our four panelists today. Our first is Dr. David Gaus, who grew up in Milwaukee, Wisconsin, and attended Notre Dame, where he received an accounting degree in 1984. After a soul-searching conversation with the then university president, Reverend Theodore Hesburgh, David traveled to Ecuador, where he spent 2 years volunteering at an orphanage, where he witnessed the marginalization of a population who lacked access to even basic health services. When he returned to the US, he re-enrolled at Notre Dame to complete his pre-med studies and then enrolled in Tulane Medical School. In 1992, David earned his MD and Master's in Public Health and Tropical Medicine from Tulane. Following a residency at the University of Wisconsin, he returned to Ecuador and soon discovered that rural hospital care was the country's greatest need. In 1996, David and Father Hesburgh started Andean Health and Development to provide self-sustaining comprehensive healthcare to the rural poor. Their pilot project was a hospital in the underserved community of Pedro Vicente Maldonado, or PVM, and this hospital opened in 2000 and became financially self-sustaining in 2007. Hospital PVM provides high-quality care to an extended community of 80,000 and is a training ground for physicians and other leaders in their community. A second teaching hospital and clinic, Hesburgh Hospital, opened in Santo Domingo, Ecuador in 2014. Both hospitals have public-private partnerships with the government of Ecuador, and AHD trains 15 Ecuadorian family physicians annually. One of our other panelists is Dr. Neela Bhattacharya, who is a plastic and reconstructive surgeon working in Anandaloke Multispecialty Hospital in Siliguri. She completed her MBBS from Madras Medical College in 1991, her MS in general surgery in 1994, and further super specialization in plastic surgery in 2006. She started the first department of plastic surgery in North Bengal. She is also the project director of the Smile Train program, wherein she operates on infants and children with congenital cleft lip and palate totally free of cost. Over the last 14 years, she has restored smiles to more than 5,000 children from areas near Siliguri and the rest of North Bengal. She is the sole coordinator of the cleft care programs of the West Bengal government under the RBSK scheme, the Border Security Force, and the Sahastra Seema Bal, and the Rotary Club of Sikkim. In 2016, she was recognized by the Ministry of Women and Child Development, Government of India, as being one of 100 women achievers in India. And in 2017, she was recognized as one of 25 women transforming India. She's the recipient of the Women Icons India Global Award 2019 in Healthcare, given by the Governor of Tamil Nadu at Chennai, and Shakti Saman 2019 Women Achievers Award from the Governor of Sikkim. She also received an award for an excellence in plastic and reconstructive surgery from the Venus International Foundation in April 2019. Dr. Janvier Hitayezu is a Rwandan pediatrician affiliated to the University Teaching Hospital of Kigali, CHUK, which is a French abbreviation for the Center Hospital University of Kigali in Rwanda since 2016. He did both his medical school and residency training at the National University of Rwanda. And since joining in June of 2019, he has moved to Nairobi, Kenya, where he is currently pursuing a fellowship training program in pediatric emergency and critical care under the University of Nairobi. His special interests include, among others, pediatrics and global child health, emergency and critical care, genetics, medical research, and teaching. And last but not least is our fourth panelist, Francys Crevier, who has been serving the Indian country for over a decade. She has served in various capacities from clerking to tribal supreme courts and working for the United Nations Special Rapporteur of the Rights of Indigenous People to representing tribes as an in-house counsel and special prosecutor. She joined the Indian healthcare field in 2015 to advocate for better healthcare in Indian country, as well as educate tribal members and communities on alternative healthcare options. She joined NACUI in 2016 as the policy analyst and the congressional relations liaison, and later became the director of governmental affairs. As of 2017, in August, she is now NACUI's chief executive officer. Francys received her JD from the University of Arizona Law with a certificate in Indigenous Peoples Law and Policy, and her BA in Public Administration from Florida International University. Please help me in giving our panelists a warm virtual welcome. So I guess we can just go straight into our first question. Can each of you talk about your personal, professional, or research related to global health and how that shaped your definition to health? We can just start in the order that I introduced everyone. So Dr. Gaus, if you want to start.
Sure, thank you, Bhavna. I would say that in order, maybe a more important question for me to answer is how it shaped my view of healthcare delivery, because if we talk about health, we could talk about that for hours, and a lot of other smart people have already addressed that issue over the years. But where my professional development has left me with a number of reflections about healthcare delivery, and especially as a foreigner working in a different country, it's given me an opportunity to have a foot in both places and to see the challenges of both healthcare systems and look for the strengths and weaknesses of both of them. But I can tell you that there are a number of things to talk about, but we're limited on time. I would say that as a foreigner working in a country like Ecuador, horizontality, which was something you mentioned, is probably one of the first things that I needed to learn and understand more profoundly, and to see myself not as a real healthcare provider, even though I'm essentially a clinician. I've become an administrator over the years, but probably the most important thing I am is a bridge to connecting resources from outside of Ecuador to and putting them in the hands of really bright, well-trained Ecuadorians who otherwise don't have an opportunity to use those. So in terms of healthcare delivery, I personally see myself as a bridge. Another thing that I have learned about healthcare delivery is, and this will probably come up later on, but is the incredible power and hegemony of the Western biomedical model and its influence that it has in issues of the colonization, the medical colonization of places like Ecuador, and what that means. And again, we'll probably talk more about that subsequently. But I've also learned that it's not, and probably as a continuation to that, we went into, and by the way, our organization is not a missionary organization. I have, no, there are probably places in the world where missionary hospitals and things like that, they're the only facility around for hours and hours and hours. And so there's probably a place in the world still for some of those kinds of organizations. But the problem with those is that they're generally characterized that people from somewhere else who bring in a lot of resources, and when those programs end, they leave a community at even greater risk and exposure than before they got there. So from a sustainability and from a development perspective, I'm not a fan of the missionary model. But I'm just saying that we are not a missionary organization in that way. And our goal on self-sustainability and creating local infrastructure and working through the healthcare system itself is of the utmost importance. I can stop there. We can talk more about these things later, but thank you.
Thank you, Dr. Gaus. Dr. Bhattacharya.
Yeah, thank you for inviting me for this panel, Bhavna. So, yeah, as you know that I'm a plastic surgeon, and to talk about health, I think first I'll tell you the scenario in India. India is a very varied country, though it's a small country. It is a country which is unique in the sense that we are divided by our language. So in each part of the country, the language is different. So I come from south of India in Chennai, and where the street in which I lived in, there were 3 plastic surgeons in Chennai. And then fate or destiny or whatever brought me to the north of India in West Bengal, in the foothills of the Himalayas, where the whole region of North Bengal did not have a single plastic surgeon. So when I went there to practice, and when I talked to so many hospitals to take me on, practically nobody knew what plastic surgery was about. They said, we don't even need plastic surgery in this part of the country. So that was the level of knowledge at that time. Okay, I remember when I joined the hospital first, and then there was a man who had come in with even doctors there did not know what a plastic surgeon should be doing. So I remember a man who came in with his hand hanging by the wrist with a small skin bridge, and then the hospital deemed it fit to call the general surgeon, cut out that small skin bridge and close it as an amputation stump. And when I heard that, I was crushed. I said, you have a plastic surgeon available who will be able to put back that hand. So please call me whenever such a thing occurs. Please don't allow them to go like that. That was at one point. Then after maybe 6 months to 1 year, the second patient comes with the same sort of a problem. Hand comes in a plastic bag in this patient. Fine. I explain everything to the patient, what that I will be able to put back your hand. It may not be functionally as sound as before, but we can work on that in later stages, etc., etc. And then I offer him the option of replant, and I tell him I'm in a private setup, not in a government setup. So I tell him that this is going to be the cost of your surgery. We will attempt it because it will take about 7-8 hours to do your surgery. So this will be the cost, etc. And the patient turns around and asks me, Madam, what will it cost me if you don't reattach my hand and just close the stump? That is when, and the patient went for the second option after knowing the cost. So that is when the concept of health really struck me firmly, that for health to be a measure which can be provided to all, there has to be two important things. One is it has to be accessible. That is true. You should have the training. You should have doctors who can deliver it at the ground level. One. But second, it should also be affordable. There is no point in me knowing to do a lot of plastic surgery when I cannot reach out to the people at their socioeconomic level. So for me, I think that was a turning moment where I understood what health in a community is all about. It has to be more affordable and accessible to the population. And I run a program called Smile Train. I think we'll talk about it a little more later, where I can tell you how exactly this is having an impact on the health in this particular community because of the certain aspects of how the program is shaped. So I think I'll stop now, and maybe the next panelist can take it up.
Thank you, Dr. Bhattacharya. Janvier.
Thank you for having me on this panel. And it's been an honor to be invited and participating. And I think I will learn from both participants, but also the panelists. As you mentioned, I've been mainly in a clinical practice. And when it comes to global health, most of the conditions we deal with on a daily basis and causing a loss of many lives, especially childhood mortality, because as you mentioned, I'm a pediatrician. There are things that are preventable. I can mention diarrheal diseases as one of the top killers in our parts of the world. So I have a feeling that we still have a lot, or we still have to put more efforts in preventive measures through education and other means. Now, for instance, I conducted a small survey in my hospital back in Rwanda about breastfeeding practices, because I was observing deficiencies in maternity wards where mothers have a high tendency to give artificial milk, where there is really no indication. The main problem was simply because they are lacking good education about breastfeeding and its benefits, not only for the infant, but also for the mother and the family in general. And as we can read from World Health Organization or World Bank reports, how breastfeeding can be one of the intervention which is cost-effective and powerful measure to prevent diarrheal diseases. So this was one of the things I was saying, that we really need to not only put more efforts in curative measures, but also on prevention. If I'm to give another example, is about I think Dr. Neela mentioned about plastic surgery, but I was seeing many Down syndrome patients, and one of the problem these patients or these children have is because almost half of them are born with congenital heart defects. And when it comes to surgery or corrective surgery, we are depending on missions that are coming once a year, twice a year from the Western world. And when you see these people Down syndrome, they are not a priority to benefit from surgery. there will be a kind of selection when talking about prognosis, which can have a good prognosis is if he or she is offered surgery. So I could see these babies born with Down syndrome being excluded because they are probable when we look on long-term prognosis, the prognosis is not good. So I was involved in a private organization that was trying to help children with disabilities, and that's how, well, another example I can mention about global health. So they are marginalized people because of the way they are born, not because they can't have access to healthcare or they don't need it, but because of the selection that is imposed by the society or the economics or other sort of structure in the health system. I haven't mentioned the reason that I joined the critical care training because as of now, we don't have any trained personnel in pediatric critical care. So you can imagine if I'm to complete my training and be the only person in this field. That's among other, I can say, shocking observation when it comes to global health. So maybe as we continue discussing, I may give my personal point of view on different topics, but global health is wide and we have many things we can contribute as on my side when we are talking about clinical or bedside practices. Thank you.
Thank you so much for that answer. Francys?
Good morning or good evening, wherever you are. My name is Francys Crevier and I'm First Nations Algonquin. First Nations Algonquin, First Nations, the term means that I am Canadian. My tribe is from Canada. And for the purposes of this conversation, I will, I represent the National Council of Urban Indian Health. And in this conversation, that means American Indians and Alaska Natives in the United States. And so my background is in Indian law and policy. I have a certificate in Indigenous law, and I've been at the National Council of Urban Indian Health for over 5 years now. And so what we do, just a little bit about colonization in America. In the 50s and 60s, the United States decided that they would terminate tribes and relocate our people off of reservations and into urban settings. And that policy was called Kill the Indian, Save the Man. They took our children, they put our children in Christian schools, gave them Christian names, cut our hair, we couldn't speak our language or celebrate our culture. And for centuries, but leading up to this time when they were trying to just assimilate us. And so in the 80s, 70s and 80s, they decided at the end of the 70s that this was not a good practice and they should stop trying to kill our culture and our people. And so today, most of us live in urban settings, which is surprising, I think, to most Americans. Even myself, who grew up in an urban setting, thought that I was like the only one. But today, 70% of us actually live in urban settings. And so, but because in the United States, because the government exchanged with treaties, we exchanged land for the promise of healthcare, housing, education, water rights and such in perpetuity. The United States has a trust and treaty obligation to provide healthcare to our people here. And the problem is here that doesn't happen, unfortunately, even today. Our system, we do have Indian health system, which comprises of the federally run facilities, tribally run facilities. So we call that self-governance, where tribes operate their own health facilities, and urban Indian facilities, which comprised of a majority American Indian or Alaska Native board that's in an urban center where there was relocation. And so the federal government acknowledged that because of their policies, their old policies, and that most of us live in urban settings, that the trust and treaty obligation follows us there. And so the government does have an obligation to provide healthcare to us. And so at the National Council of Urban Indian Health, we represent the urban Indian organizations. And so my exposure has come from, I worked on the tribal side for a while of Indian health and then moved over to the urban side. And that's kind of where I realized how, and we're legally defined as urban. And so while every other race doesn't wake up and say, oh, I'm a different kind of person because I live in a, different place, here in America, they do define us differently and allocate resources differently. And so even though the Indian Health Service is very underfunded, they only get $6 billion out of the estimated $48 billion that they are supposed to be receiving. Urbans get about that. Urbans get 1% of that. So even though we're 70% of the population, we only get about $63 million a year to operate 77 facilities. And so the system is broken. It is meant to be broken. It's working just as it's supposed to, and we're fighting every day to make sure that the government, is accountable and actually provides the resources needed to target health. And so that's kind of where my exposure came from in terms of this. And then just realizing that most of the policymakers have an archaic idea of Native Americans. There's 574 tribes in the United States. There's hundreds of state recognized tribes that were terminated during this time that were never reinstated by the federal government. So they're state recognized tribes. And there's a lot, I mean, we are, at the bottom of the barrel health-wise with a lot of these, even with COVID, we're dying at the highest rates. And there's still a lot of work to be done, to make sure that we are in some sort of decent place. So, and I'm in the DC area for those who are familiar. I live on Piscataway land, and I'm so happy to be here. Thank you all for inviting me, and I turn it back to you.
Thank you, Francis. So that was a good segue into my next question. So anyone can jump in, but what remnants of colonialism do you see in your work, in your everyday lives? And also, how would you define decolonizing global health? And what does that mean to you?
So as I was listening to Francis, and then I find that India is sort of much better off in many ways, because maybe when we were colonized and when the people left, then all that was left behind was native people. And so we could sort of frame our own laws. We knew how to take care of people who were relegated to the background. So we start off here with having reservations. When there are in India, they are divided by caste system. I think you may know there were people who were Brahmins, they were called the forward caste, and then some people were called Kshatriyas, who were the warrior class, and then you had the business people, and then you had the people who were lower down, the laborers. So there were 4 types of class system, and that was prevalent from a long time in our country. But it was generally recognized that the Brahmins or the forward castes were doing much better. And that when we framed our own laws, we started relegating a portion of all our seats whether it be in college, whether it be in schools, and even health and wealth allocation for the reserved categories, that is the backward classes. So in that way, a lot of symmetry has slowly been achieved over the last 75 years of independence. So much so, sometimes I feel that the forward classes may be the people who are now slightly persecuted, because 70 to 80% of the reserved seats go to all the reserved categories. Okay, so that is one way where you stop privileges from accumulating at one particular sector and make it accessible for all the population. So equally for all the population. If you are able to do something like that, then I think a health system can develop better. So that is one. And remnants of colonialism, I think the only thing which is remnant now is that we learn everything in English. Still our offices work in English. But that is again required in our country, because otherwise the language is different in different places. So if you have to have a unifying language, maybe it is our national language, which is Hindi, and that has a lot of problems of acceptance in different parts where Hindi is not the main language. So we accept English and it still goes on. So maybe that is the only thing which reminds us that we were colonized at one particular time.
I would say that in Ecuador, there's a number of things that contribute to the persistent colonization, the medical colonization. One of them is that there's very little scientific production that comes out of Ecuador. And so Ecuadorians tend to follow whatever comes out of the industrialized world. And that happens on purpose. That's by design. And that kind of goes back to my other comment earlier about the biomedical model of medicine. For those of you that don't really know what that refers to, but the biomedical model is really an exclusive focus on the biological factors of health and on reductionism. Hegemony, when we talk about hegemony, we usually think about it in terms of geopolitical aspects, but hegemony is really, it applies to medicine as well. It's the power that, it's basically the ability to suppress other alternative options in terms, at least in the medical sphere. It's to encourage and prop up and continue to foster the biomedical model exclusively, and not acknowledge other ways to look at health and healthcare services. And so all of the funding, most of it gets placed for research, gets placed into research projects that are based on the biomedical model. So that's why quantitative analysis, most journals you read in medicine are quantitative articles, and that really feeds it. That's all part of the biomedical model. So the hegemony of the biomedical model is still really strong, and we see that as a huge obstacle in Ecuador, because if you can't contextualize, the problem with the biomedical model is if you ignore the psychological, environmental, and social factors in medicine, then you're not going to get too far, especially in a country like Ecuador, where the cosmovision or the worldview of the people of Ecuador doesn't necessarily fit with Western medicine. So how do you overcome that? And so that's another reason why we continue to we persist as a colony, because of the hegemony of the biomedical model. So for people read, for example, I know most of you aren't clinicians that are in this on this call right now, but there's a website called Up to Date that is clear. It's a great service. It's a great option to get some quick information, but it's obviously not culturally contextualized in any way, shape, or form. It's pure science that might not have any translatability to different places in the world where those things aren't available. And then I would say the other aspects of why this place persists as a colony There's also some internal reasons within Ecuador. And there's many of them to talk about. The only one I would just like to highlight is that people really aren't prepared for leadership positions, and ministers of health change every 6 to 12 months, and there's no long-term vision or mission for the organization. And so when you've got a vacuum in the leadership perspective, on the leadership side, the giant bureaucracy behind it doesn't know really where to go. And so it's all about kind of self-perpetuation. And so that leads to a lot of other challenges. I actually wanted to ask Janvier a quick question about his concept of, and this is, I think this relates to colonization as well. It's interesting, Javier, you, on the one hand, you talked about the importance of preventive services. On the other hand, you're training right now to be quintessentially a curative provider right now as a critical care doc. I just wanted to say that our team in Ecuador, our Ecuadorians, have long wondered why the United States, in terms of global health, spends so much time talking about prevention as the key for developing countries, when in fact, and for the rest of the world, when in fact the United States spends so much of its health budget on curative services. And our Ecuadorians would say that that kind of makes sense, because the philosophy here, at least within our group of our team, is that if you don't have good curative services, people aren't going to access your healthcare system. And if you don't have access, if you don't have people using your system, you don't know what the problems out there are in your community to prevent in the first place. And so there's kind of a feedback loop that curative services and preventive services must go hand in hand. But for some reason, in the United States and Europe, we love talking about prevention and global health, but no one talks about curative services. I just wondered what your thoughts were on that.
Well, thank you very much for the question, but I think I will start where you ended. I will personally, I'm convinced that these things or these two approaches have to go hand in hand, because I gave an example of diarrheal diseases. So we have a good deal to do on the side of prevention, but if you look at the numbers of patients who are received with their complications, let's say from these diarrheal diseases, they are the ones to end up receiving critical care in ICUs. So it's somehow painful to see someone suffering from diarrhea. We have these simple means of treatment, but they end up in ICUs having dialysis, or they are not even having access to dialysis treatment because it's not available. And if they are not receiving these services, of course, they are going to die. So that's how it becomes a very a complicated cycle, and but which, if we would be working properly, trying to work on both prevention, but also on provision of putting on their access, their quality care, we will be able to avert these diseases which are not necessary or which are not explained. So in one word, they should go hand in hand. And if I'm to make a comments on the questions that the moderator has asked, when talking about the colonization of global health, my understanding, I will say that's a sign of a very large vicious cycle of cruelty, where only a small group of people want to lay hold of seize at whatever cost all the resources and wealth of the world, as it was, or as if it is their personal property. And if we look, this is happening within small communities, inside individual countries, at the individual countries level themselves, at the continental level, or between the continent, and etc. Let's look, for instance, gunfire conflicts that are happening around the world now. they are pushing millions of innocent civilians to flee their homes, and if they are not killed, by the way. So these people will find themselves without a shelter, without food, and they're dying from extreme hunger. Their children and other members of their families are going to have severe malnutrition and all related infectious complications because they have no access to healthcare. So if I'm to solve the problem of healthcare access, I'll do my best to stop these conflicts, pushing people to live in chronic distress in refugee camps, and they are suffering from the malnutrition. And I'll be coming back to a simple situation, not a simple, but a painful situation where people are dying because they are simply getting diarrhea. So living in a refugee camp, that's a good or a sad environment where you are likely to get this disease, die from cholera. So there are a number of sectors that need to be sorted out when it comes to the problem of inequity or injustice that is available at different levels within individual countries, but also at the international level. The remnants of colonization, one of them I will mention the teaching languages from former colonial powers, as my colleague from India has mentioned. And the same languages are the ones that are likely to be used in different official public services. So you can imagine, if I'm to give an example of my home country, we have only one language for one national language for where every single native person there can speak the same language, the maternal language. But you can find yourself in an office where you have, let's say, people who have written their signs or their panels in English or in French, and maybe the ordinary citizens or she or he can speak is the maternal language. So this is, to me, it's one of the remnants of colonization. Another example you will see for higher level of training, people still have to travel overseas, which has been linked in most of situations we belong, or this chronic brain drain, where some of the qualified individuals decide to stay outside their home countries. So if we are talking about the health, if you have trained personnel specializing in different disciplines of medicine who are not returning to their home countries, so that's where we want to expect this quality care we are dreaming for. So I think we have a number of fields that need to be worked on to be able to put an end this painful situation of global injustice and inequity, not only in the health sector, but also in different sectors of our daily lives. Thank you.
And I think I mean, we see a lot of colonialism, I think, in our work here. Blood quantum is still an enforceable thing, and depending on how much blood you have depends on if you can get services in the Indian Health Service. So while the 1 drop rule, was ended in the 60s, it's still very much alive for American Indians and Alaska Natives here in the U.S. There's not a lot of credence in America for evidence-based practices. I mean, that's what they do, is evidence-based practices instead of practice-based evidence. When it comes to some traditional healings and stuff like that, that's hard when it comes to the Indian health system as a whole, and just generally in this country. Native practices are not as well recognized and reimbursed when we're talking about, you know, sustainability. So I'll give you kind of an example. One of my friends in Arizona, he was Navajo, and he went to the federal facility, and he had diabetes, he had liver issues, he had kidney issues. He was in a really rough spot all of a sudden, and it happened really, really quick. They did not want to do any support any traditional practices, but they did put him on westernized medication, which kind of it hurt his organs a lot more. And so he was in chronic condition. He went to his reservation back home, and they performed a 3-day healing ceremony on him, and he doesn't have diabetes anymore. And those are things that are not as well recognized in the US as they should be, or paid for, which is part of, you know, the poverty and not allowing those things to flourish. And the language barrier issue, there has been many times where patients don't have access to a translator, and even if they're on their own reservation and it's a federal facility, they do not have traditional, they're not required to. And so that becomes a huge challenge when it comes to care. Everyone is supposed to speak English, and I know in America that's like you're thinking that's normal, but especially on reservations, some folks do not speak English, and that can be very common in some areas, in some very rural areas, and so that also becomes an issue. And then one other thing, I think in our federal facilities specifically, a lot of them are still Service Corps officers, and so they're wearing their, you know, uniforms kind of as if until 1955, Indian Health Service was in the Department of War. And so we were considered terrorists. If you recall those issues with Osama bin Laden, they actually called it Operation Geronimo, which is really sad because that's one of our very admired tribal leaders. And so there's a lot of challenges here, and colonialism is still way at the forefront and very, very present in today's world.
Thank you for those answers and for the discussion. I do see some questions coming in from some attendees. So before we move to questions from the audience, I just wanted to ask one last question for everyone. What is the current narrative around marginalized groups that you've noticed in your personal or professional lives? And what is something that we can do just as the general public to sort of change this narrative?
I can start. So I think the current narrative in the US, and it doesn't just go for American Indians and Alaska Natives, it's for a lot of our minorities here, that we have, there's a narrative that, you know, oh, we're vulnerable populations. And what that suggests is that our bodies are somehow inferior to everyone else. But what it really means is that the reason we're so vulnerable is not because our bodies is inferior to our race, it's because of centuries of systemic oppression and access to healthcare, and you know, all this historical trauma that has happened, that still happens. I mean, some of the founders of my organization, my organization's been around for a little over 20 years, and they were boarding school survivors, people who ran away from you know, nun boarding schools, and were captured by the FBI and brought back. You know, it's still very, historical trauma is still very, very tied in there. And so for me, it's more about changing the narrative, is more about fighting systemic oppression wherever you go, always looking out for potentially marginalized groups, and making bold action and putting values over dollars amounts, which is really, in the United States is obsessed with money, but not for the people. And so that becomes a huge problem. But I definitely we have been actively trying to change the narrative around being inferior, our bodies being inferior, because we just know that that's not the reason why that we are having such high rates of disparities.
In a country like Ecuador, more than 50% of the population is marginalized. So it's the majority of the population. And so, but if you're going to talk, if you would talk specifically about certain subgroups like indigenous populations and even the poorest of the poor mestizo population, it ultimately becomes a political manipulation. So the narrative becomes popular when it's campaign season, and once elections are over, it kind of it dissipates again. And so the thing that I've always been fascinated by with the narrative is again, and I think this comes from largely from international aid agencies, is the whole idea that we can apply that the solutions are merely technical. If we could just get more women to breastfeed, if we could just get more iron into kids, if we could get more cancer screening done. But I think that's a very naive and myopic approach. I think any decision that ever gets made that's got any degree of complexity, at least in Ecuador, always has 4 levels to it. The technical criteria is the first one, but after that comes the political will. Is there a political will to make that happen? And then thirdly, is there financing behind it? And then finally, are the lawyers going to shoot it down on some legal aspects? And so to live exclusively in the technical world of those decisions, I think is incredibly naive. But I think that most of the international aid agencies try to live in the technical solutions. And even when they know they're making blatantly political decisions about the resource allocations, and they're couching it in technical terms, they even realize that that's not a valid approach. And so I think the narrative is influenced greatly by the powerful institutions that decide what that narrative should be.
Yeah, I can quote the example of the project that I am working in, the Smile Train. That is basically an NGO with the headquarters in the USA, actually. It works on donations, and all in about 135 countries, they carry out this project of giving free cleft surgery for poor or children who are affected by that. Now, how common is this cleft disease? Every 3 seconds, a child is born with cleft in the world. So it is that common. And so the Smile Train has taken that specific goal that we cannot save the world, we cannot achieve global health, we cannot do any of those things. So let us at least tackle one disease. And so the donations go out, and then the program is successful, and it works only because it is run by the local doctors who are trained for this. If it was something where for 2 weeks somebody will come from outside to get this done, then it will not work. Because I am there in that population, and what is this population which is in North Bengal? It is a population which has some of the poorest in the country. I'm not only in North Bengal, it's from neighboring Nepal, from Bangladesh, from the other state of Sikkim, from all those areas, Bhutan. People come to Siliguri for treatment. And the poor people, we even have to give them travel conveyance to come to the hospital for treatment. So if you are really going to do something at grassroots level, you cannot wait for political will. It will never happen. Aid also, it is good that we have one NGO which is willing to train and provide infrastructure at the local level, that also is not always feasible for all diseases. So we will have to start improving our literacy, have to make our people more come into the mainstream where they have some access to education. Remove ignorance. How much ignorance we are having to deal with in the population. We tell them come for I gave nutrition to a small child who had a cleft palate, and then the child did not come for another 6 or 8 months. Nutrition, that means I have given the child food for 1 month. That is also available within our plan. We can do that. And then I'm seeing for the next 6 months, there is no trace of the child. So with a lot of trouble, we then trace the phone number of the child. And when we talk, he's saying that the locals around him have said that the child will become all right if the child grows up. So don't go for surgery. So it is that amount of ignorance and illiteracy. And so these are the main problems that we will have to handle at our level. It may be some for maybe election or gimmick or whatever. The politicians offer certain things. They say free literacy for women, free food for children in schools. All these things are there in our country. We'll have to use all these to our benefit and make them a little more literate, combat ignorance. And maybe when we can do that at that level in local community and uplift the local community, maybe then we will be a little nearer to achieving a little more equitable health for our community. So I think that is how we'll have to approach this problem.
I have a question for Dr. Bhattacharya and Francys from one of our attendees. Has being a woman navigating the healthcare space influenced your journey or your perspective on health, global health, colonialism, any of those?
Since we're in America, well, I'm in America, I'll talk about kind of expectations, I guess, that the people have of women. So I am not what I guess folks would consider traditional at this point. I'm not married, don't have kids, don't want either of those things. And so I'm not, in love with, babies or anything like that. But I do find in North America, there's the Missing and Murdered Indigenous Women or People Initiative, depending on who you're referring to. And in our country, a lot of Native people go missing or murdered, and law enforcement does not look for us or help us. We as an Indian lawyer, I thought in that field, it was a thought process of, because we do not have jurisdiction over non-Native people. We only have jurisdiction over Native people. And so we find that border towns that are on the reservation. So in America, every race hurts itself at the highest rate, right? White on white, whatever. But in Indian country, it's actually 80% non-Native and white perpetrators. And so when you know that, and we don't have law enforcement abilities and stuff like that, I think that informs a lot of what I do to try to empower our communities in terms of things that can empower our facilities and our communities to better respond to these things in the urban area where there are no jurisdictional boundaries. But we try to provide resources like domestic violence services, housing services, mental health services, stuff like that. And it depends on each facility in the United States here that's an urban Indian facility. They are community-based needs, which means that they respond to what the community means. So if there's like a large homeless population, our Albuquerque facility has washer and dryer and showers and things that the homeless population has requested. But we also have she had a huge human trafficking building, because that is a huge reason why we go missing and murdered. And so trying to respond to those social determinants of health. And so I think in that way, women are truly, forgotten about and not taken care of. And it doesn't seem to matter too much. There's a law here called the Violence Against Women Act that helped give tribes a little jurisdiction, but not a lot. And it's gendered. And so it's like, and you have to be like a woman being abused by a man, can't be a woman abused by a woman, and can't, the person can't rape you because they're your boyfriend. And so it has to be a stranger. So there's like these weird things about how they define our safety, and it just really continues to put our lives last. And so that always frames how I'm, walking into this space. And I am on the national task force under the Department of Justice for violence against women, and just trying to make sure that, to close that gap and make sure that our people are not getting missing and murdered. And so that is a huge thing for me.
Actually, being a surgeon is essentially a man's field. So when initially I wanted to do surgery alone, there were a lot of raised eyebrows. And apart from that skepticism, if as a woman, as a surgeon, you have to show that you are good a little more than what the men folk need to do. Okay, you need to be a little more sincere. You need to be, because when I joined surgery also, my teachers themselves were not willing to take me into the unit. They said, she will leave in 6 months time. She's not going to stick around, so don't waste time on her, something like that. So you have to tell them that you're serious about about what you're planning to do. And even when you come to a new place, I was not even conversant with the language of North Bengal when I came in here. And when you're coming in with a new field of plastic surgery, which is not there at all, and all are just again in doubt as to what this lady trying to achieve. What do you really think that she will fit in? Most people even now tell me, "Are you a gynecologist?" Many patients who call up, they said, they say, "Are you a gynecologist?" Because traditionally it is a gynecologist who's a lady in our country. So that is these are the small challenges you'll have to really have from if you're a man, you are slightly more accepted if you're a surgeon, but once people know you, once they know your worth and what you can do and how you deal with people, etc., then I think everything falls in place. That one initial hassle we'll have to face, and we shouldn't be faced by that. That is all. So I think as a woman you can do wonders at whatever you want to do. You should have the courage to do it. That is all.
I'd like to add something to that. Thank you, Dr. Bhattacharya. So in Indian country, a lot of us are matriarchal. And so it is very common that the leaders are women. Not that we're all, not all, but a lot. And so it's not as challenging in my field as it is outside. But because my people support me, and and it is so normal, it is helpful, because when I have to talk to these some of these racist policymakers, it does give me the confidence knowing that my people support me. But it's not within my field. It's not uncommon at all that women are the heads of any organization and the leaders of everything. So in fact, most of the Indian orgs in DC are run by women. So what outsiders think about that, they don't tell me to my face, but inside it's good. It's going good.
Thank you both for that. Another question from an attendee is if you faced any conflict between the culture where you're working and Western medicine, and how you deal with those challenges.
I could answer that briefly. Yeah, Western medicine is how it's accepted in a community is highly variable. I can tell the story of an old man. I was walking down Main Street in our small community after about 5 years of the project being up and running, and an elderly gentleman came up to me and said, "Hey doc, I got to tell you something. I guess it's good that this hospital's here, but in the old days, people just in our town, people they were born, they lived, and then they died, and it was really pretty simple. But now everyone's got all these diseases, and they're all taking medications now, and it's just I don't know, it's just not the same like it used to be. I guess it's good that you're here, but I don't know. I don't know. So the worldview is really there. The cosmovision of the community is of the utmost importance. And we thought when we came here as an organization, and we meaning I, the only gringo, and everyone else was Ecuadorian, we thought that we were going to bring 21st century medical technology to this community and really move it up. And the fact of the matter is, what we've got now is probably more of a hybridized healthcare system than anything else, which it probably should be. I don't know where we are in that timeline because of the hybridization, and traditional healing is a critical part of this. We don't do any traditional healing. We don't know how to bill for it. And the fact of the matter is, we think that healthcare systems in many countries around the world make the mistake of trying to offer Western and traditional medicine, when in fact, it's usually the patients themselves that know when they need to go to a traditional healer and when they need to go to a Western doc. And we have this thing called the path to the cure. And when people get ill, and by the way, this isn't all that different than the United States, but when people get ill, the first thing they do is they ask grandma for some kind of a concoction. If that doesn't work, then they go to a healer. And if that doesn't work, then they go to some pharmacy in town. And pharmacies in Ecuador aren't pharmacies in the States. You don't have to have any kind of a special license to run a pharmacy. So you could be selling Coca-Cola one day and the next day you're selling antibiotics. And people come in and say, I've got this or that, what should I take? And someone turns around, rubs their chin and says, why don't you try this? And then if that doesn't work, then they plug into the Western system. And so we humbly recognize that we are like number 3 or 4 on the list of healthcare providers for them to access it. But so we don't pretend to know the traditional healthcare system, but the people that are traditional healers, to the extent possible, we work with them. We had a kid, and with this, I'll finish this comment with a quick story. A kid, we had an X-ray tech that we brought in from another town to run our X-ray machine many years ago. And the guy was kind of lazy. He didn't work much, and we didn't have a lot of films to do. So he read the paper in between doing X-rays, and we didn't like that. So we hired Carlos, a local kid, a mestizo kid, to learn how to do the X-rays. And after about 6 months of him learning how to do it, we fired the other guy. And Carlos, being a local, spent a lot of time and knew most of the people that were the masseuses in the community that would fix bruises and wounds and things like that out in the community that weren't part of the Western model. And occasionally they would suspect a fracture underneath one of those bruisers. And so they'd send the patient in to see Carlos. And Carlos had this cool machine where you could see through the skin and actually look at bones. And so Carlos would do the X-ray, then he'd pull one of the physicians aside and say, hey, is this a fracture or isn't this a fracture? Then Carlos would fill out a report and Carlos would send it back to the traditional healer. So that was one way to try and mix those things. But we clearly recognize that the Western medical model has severe limitations. Obviously, it's done some incredible things as well. I won't deny that. But again, it's got to be contextualized. And the answer is probably somewhere in the middle in terms of you bringing a community up to the 21st century using Western medicine and them bringing you into their own worldview and you trying to figure out a way to hybridize that.
Thank you, Dr. Gaus, for that. So we have about 10 minutes left in our panel. So I just wanted to thank you all for coming. I wanted to ask one more question, and then if we have time, we can go back to more questions from the attendees. But because a lot of our attendees today are undergrads and college students, what are some things that we can do as college students starting now to change the narrative, and how can we work towards changing healthcare structures so we can have more health equity and more equality and fairness in our society?
I would say don't accept the status quo. For marginalized folks, the system is working how it's supposed to. It's failing folks. And so I would continue to question structures, policies, and the good old term, this is the way we've always done it. And really, consider the patient first and their experience and how it would make them more comfortable, and want them to come back. And if there's a cultural component, just come in with, I would say, a lot of humility, listen more than you talk, and be open to your way not being someone else's way. You're there to serve them. And so what you may consider to be a norm is not a norm for them. And so just be really open-minded. Here in the US, there's been a lot of brainwashing for colonization. It's in all of our brains. If you're from the US, you have it in you. And so be active in asking yourself about those biases, and as they're coming up, just always think about those marginalized populations and how they would operate, how they should be, what they deserve, and how to get it there.
Well, if no one's going to say anything, I'll jump in and tell you that as an American living outside of the country, I would throw that question right back at the people that are asking it and say, what do you want to do? Where is your passion? Because if you're really going to do something that's significant, this is a lifelong calling. This is a vocation. And a vocation for me is finding a passion and then finding a way that the community can benefit from that passion. That's what a vocation is, as opposed to a career, which is kind of a retrospective diagnosis. At the end of life, you say, I worked here and here and here. And so if you don't have passion, you're going to burn out because you're going to be going upstream your entire life. So if this is something that just seems, and I don't want to offend anybody, but if this is something that just seems kind of cool and a neat thing to talk about over a cup of coffee or over a beer, it's probably not going to last. And so I think you have to do a lot of introspection and really figure out what you want to do. And if this is it, well, then it's an easier conversation to figure out how you can change the narrative. But I will tell you, in my work in Ecuador, for the first 10 years I was down here, if I had one good day a month, I was rocking and rolling. You're working upstream all the time. You're working against a system that's rigged. You're trying to introduce things. You're trying to find local partners. It's consensus building. It's political. And it's just really hard work. I'm not saying that to get a pat on the back, but this is no small challenge. This is a gigantic commitment. So if you're not passionate about it, you might want to just consider walking away from it now. And finally, you don't have to be a physician. A lot of us are physicians. Francys is an attorney. See, that's a great example. You don't need to be a physician. I mean, I was an accountant in a previous life before I came down here to Ecuador, and now I probably do just as much business administration as I do for clinical work. And so there's a million ways to get into global health that is not necessarily through one of the specific health or allied health fields. And so you can be a whole number of things, but first and foremost, there's got to be passion.
I would say that too, in a sense that passion will keep you alive on really hard days. It'll keep you going, because that's kind of what we do here. You know, sometimes it's 24-hour days where Congress needs language right now, and that language will help patients or kill patients. And so you have to be, you know, it's been we've been very diligent here, and so we just look back and are very thankful for the passion that we have, because that is the only thing when you have no sleep and have to continue fighting the good fight, and everyone expects you to, regardless of, you know, what you're experiencing. And so it is the passion that also helps you. It's the gas in the tank that keeps you going on in bad days when it's really hard to keep going.
Well, on my side, I will say this is a very complex concept. And I think the roots of these injustice and inequities reside in that predatory capitalism. So if we could put an end to this nature of capitalism, stop the conflicts ravaging the world, and which in a way or another are backed by the superpowers because of their different interests and geopolitics on competition, we will not see any more people dying or in refugee camps from hunger or different disease pandemics. So what can a college student do? I think it's to continue to shout against this global injustice and inequity and make your movement a kind of a worldwide organization to have a more powerful voice, that healthcare is a right to everyone, not a privilege for some. That current capitalism is a kind of a crime against humanity. That we should put to an end the gun noises. They should be silenced around the world. That no one should lack food, for instance, or lack clean water and other, I would say, essential needs of daily lives. That this world is not poor, but people have made a kind of, again, talking about this capitalism, there is a very large and wide or deep ditch between the rich, mainly these people in power, or the ones that have means, industrial people. They want to keep being rich, and on the other side of the ditch, there's the poor, the ordinary people, the ones who is forced to flee their home life, their home, and find themselves in this chronic distress. So keep fighting this and make this a kind of worldwide movement, and maybe at some point we have a success. But it's a lifelong fight if we are to reach this point. Thank you.
Yes, I think the panelists have all made their positions clear, and there are people who are asking how they would contribute in global health and how to get started and things like that. As Dr. David said, there is you need not really do something phenomenal. You start off at whatever level you are in, and try to do something which is going to affect your community, because there is nothing. There is a struggle only at your community, at your level. Okay, try to change something for the better at that point, and it is going to be very, very difficult. It is not going to be easy to do even the simplest of, in my community, we have a great problem of spitting. You cannot tell a man not to spit on the road. Okay, because that is against his basic right. So we keep on making small films about how spitting is going to cause so much of spread, so much of disease, so much of it is, and the government tries to impose fines. Fines works in all other parts of India. South India essentially, again, and because of the differences, it's a place where people don't have this culture to spit. But if around me I tell any man who spits don't, then he will take it back at me. He says he may even hit me for telling him something. So these are small, but it would make a huge impact if we are able to stop this coming in the community. They say even tuberculosis, the last year has been less because all of them were forced to wear a mask whenever they go into public places. So small things, try to make a change at your level, and then slowly maybe it is even a small change to make is going to be very difficult. Accept that and learn to take it up as a challenge and do it. I think then slowly you will be able to do some help for your community.
Thank you all for that. So unfortunately, that's all the time we have for the panel today. I wanted to thank all of our attendees for coming. I know it's early on a Saturday morning, but thank you for coming. I hope that this conversation for all of you was informative, educational, inspiring, and also thank you so much to all of our panelists. I know it's different time zones for everyone, so thank you for taking the time to meet with all of us today and have this inspiring, amazing discussion with all of us.